So I think we get started now. Good afternoon and welcome to today's experience sharing sessions of the IHE-Europe experience. My name is Andreas Klingler. I'm the current co-chair of IHE-Europe, and I will moderate this first slot, which has updates from Switzerland and hopefully Germany. The speaker from Germany hopefully will join in a few minutes. I'm delighted to present you two excellent and well-known speakers. First, Stefan Spani will tell about the implementation of the Swiss eMedication treatment plan. Stefan is a systems architect at the University Hospitals of Geneva and current user co-chair of IHE-Europe. So in a sense, he's also my counterpart from the user side in the IHE-Europe Executive Committee. And after that, Alexander Eels will give an update on the national policy on interoperability in Germany. Alexander is a senior digital solution expert at Siemens Healthineers, and he's an eHealth board member of Bitkom, a German IT industry association with over 2,000 members, for which he actually speaks today. Please note that your microphones are muted for the presentations. If you have questions, please type them into the chat window. The speakers will address the questions after the presentations, or you can get unmuted so you can comment directly. So without further ado, take it away, Stefan.
Thank you, Andreas. I will share my screen. Okay. Okay, welcome to this session. As Andreas said, I will speak about the Swiss implementation of an eMedication treatment plan. First, why is a good and trustworthy medication information so important? If you look at some publications and some reports, we can see that the medication-related errors have a huge cost financially, but also in terms of people impact. Like the last evaluation that was made in University Hospital in Switzerland, they estimated to 5 to 10% of emergency admissions related to medication problem, whatever they are. It can be wrong intake, too much, or drug-to-drug problems, any kind, but out of them, 3% have a fatal issue. So it's not a side aspect of for the good treatment of the patients. What is the landscape into which we want to establish such a medication treatment plan in Switzerland? First, on the national side, maybe you were already in the session this morning. We have a national law establishing the electronic patient record from 2017. It's work in progress for the implementation. The first regions are operational now. To have a full coverage over the whole country, it will probably be only in 22. But nevertheless, we have, at least in some regions, a national architect. We have a national architecture, IHE-based, regional implementations. Some are already live, basically XDS.B based. So it's document-based for the initial phase for the national electronic patient record. So implementation of initial service is ongoing. We will have about 10 communities. 4 are already, 3 are live, 4 are ready to start. On the other side, historically, we started in Geneva many years before. We started, in fact, end of the 90s. And we have a running electronic patient record infrastructure since 2010 in Geneva, and more than 50,000 patients enrolled. Our architecture is close to the national architecture and will be replaced by conformant implementation this autumn. We, in Geneva, recognize the importance of supporting eMedication quite early, and we developed the first shared medication treatment plan tool in 2011. However, at that time, this tool was developed in a proprietary way, using proprietary storage of data, format of data, and it was only available through the platform's portal for healthcare professionals and for patients. So anyway, a new concept, new implementation was required. So we decided to take the opportunity of the replacement of our regional infrastructure by one conformed with the national law, and looked at a certain number of key characteristics we have to fulfill, we have to implement for the new solution. First, of course, that was more or less the case with the first implementation. Every stakeholder may contribute to the medication plan. It includes the patient, because the patient is an actor. The patient may document the fact that he's taking some medication he bought over the counter from the pharmacy or any others. He may add comments saying, well, I do not support very well this medication, or any kind of information. So it's very important to include the patient in the loop. Another very important thing is to support both the clinical view and the logistical view. And we'll see in the next slide a bit more about that. And we have to present aggregated information, taking into account the whole flow of a medication. For example, you have the physician, the practitioner tells the patient he has to take a certain medication, but then at the pharmacy there may be a substitution. There may be also some changes during the life of the medication, change of dosage, things like that. So you have to support this workflow and to provide aggregated information reflecting the current status of a medication. It has to support medication anamnesis and medication reconciliation. Those two, especially medication reconciliation, is a medical process, and we do not think it can be performed automatically. So that's a task that will still be the responsibility of physicians to do the proper reconciliation between the existing plan and newly added medications. And it has to support the logistical process with the prescription and the dispense. Another key success factor is a strong integration with primary systems, GP systems, hospitals information systems, the pharmacist systems, nursing care also. Which means that we need to be standards-based to use interoperability standards, and especially the IHE pharmacy profiles. 2 words about these 2 layers, the clinical layer and the prescription layer, because most of the running systems addressing, between quote, eMedication, or are in general addressing e-prescription, which means that they are addressing the 2 bottom layers, which are the logistical part. It supports the e-prescription and the e-delivery, or the delivery of the medication. But if you look at the life of a medication plan for a patient, if we take the example here, the patient goes to his physician, the physician prescribes 3 medications. The next visit, the physician decides to stop the green medication to continue the yellow and the blue. Here it stops the blue, etc. There's a lot of different events. If you look at the prescription layer, the stop here has no information in the prescription layer. And here, the addition of the pink one, in this case, the patient still had a box of the pink medication at home. So no need to make a prescription. Again, nothing in this layer and nothing in the delivery layer. So if you look only at the logistical layer, you lose a lot of things, a lot of information. And what we intend to do is to support the clinical, mainly the clinical aspect of the medication. Support the clinicians, support the patient, having the patient having an up-to-date list of which medication he has to take, when and why. You cannot either consider only the top level, the clinical aspect, because if there is, for example, a substitution of one brand by another, or even possibly one galenic form by another, or a patient was prescribed tablets of 1 gram, but he has problems swallowing them, so the pharmacist substitutes by 2 tablets of 500 milligrams. It has to be reflected in what the patient sees, in the list of current medication the patient sees. So you have to consider all 3 layers. How to implement that, considering that we already had a first trial implementation? We followed a certain number of steps, gathering the key requirements, considering what we learned with the first experiment. Work for a national concept. The initial version was implemented only in Geneva because Geneva was the only region having an electronic patient record. We now have the national law, the national architecture, and progressively implementation in different regions. Moving to technical specification, implementation of proof of concept, testing and validation of the proof of concept. These different tasks can be grouped into several building blocks. Very important aspects: coordination with key stakeholders. We have in Switzerland an entity called eHealth Suisse, who is the coordination between the federal government and the regional governments, and which is following the implementation of the regional electronic patient record communities, establishing the technical requirements, defining which profiles have to be used. So we work closely with them for the establishment of a national concept for eMedication, considering that we'll have different XDS communities, that we have professionals and patients in different communities, and that has to work to be transparent for the users. We have the community that will replace the implementation in Geneva is a community for several cantons, most of the French-speaking cantons in Switzerland. So we work closely together with this association, this community, because we will implement the service as a pilot service into this community. And we're also working with one key actor in the pharmacy landscape who is managing chains of pharmacies and is implementing pharmacy software too. Working groups, business technical working groups, business to gather requirements from healthcare professionals, physicians, hospitals, GPs, pharmacists, nurses, including patients. We have what we call at the University Hospital of Geneva partner patients. It's a certain number of patients who are volunteer to contribute to different projects. And we can make a call. We have a project, we have an eMedication project, and we would like to have a few patients to discuss with them, to test IDs, to gather their feedback, to gather their IDs. So patients are included in the business requirements gathering. And working on technical working group for the technical architecture and for implementation of a pilot, setting up a pilot project. Standards, which were, when we started the implementation in Geneva 2011, it was also beginning of the IHE pharmacy profiles. And we were not very used to IHE at that time. So we started with our proprietary implementation. Now for the national concept, it was clear for several years already that we have to move to interoperability profiles and well-adapted profiles. There are profiles related to the communication, and for that we are using the key profiles used for the electronic patient record infrastructure. So mainly XDSB now, so based, but we are starting to progressively support also MHD, mobile health documents, with RESTful based API. Content profile. Initially, there was in IHE Pharmacy 4 content profiles: the e-prescription, the e-dispense, profiles for validation of prescription, for modification, and medication list. And if we think back at the drawing I presented with the medical aspect, the medical layer, this was not available in IHE Pharmacy. And we created an additional profile, the MTP, Medication Treatment Planning, which was introduced in 2015 for supporting this clinical layer. So it's really MTP is the decision by the physician. The patient has to take this medication with this dosage, this frequency. And then we have the logistical aspects with the prescription, the dispense, and modification validation. IHE Pharmacy has also a workflow profile, the CMPD, Community Medication Prescription and Dispense profile, which organize the workflow between the different steps of the eMedication process. This one has been is being extended also to support RESTful transaction. It was supporting, it is for the moment supporting only XDSB. The revision this summer will also support MHD for the access to these different content documents. And we had also to contribute with a certain number of change proposals to IHE Pharmacy, IHE-ATI, IHE-PCC, in order to better support the use cases we have. As usual, it's always based on real use cases. We had the use cases and we went to the different IHE committees. I'm part of IHE Pharmacy since 2014 to say, well, okay, we have these use cases, that's common use cases, and maybe we should enhance slightly the profiles to support that, which was approved. We also have created a national exchange format because there are some specific aspects for Switzerland. Trivial ones are the referential for the medication, which codes do we use for the medications, for identifying a healthcare professional, etc. There are a few, and we created three profiles, two content profile, CDA, CH, eMed, which is based on the five content profile, MTP, PREDIS, PADV, and PML, but with the specification, the specializations with the national aspects, and a specialized medication list, which is the current treatment of the patient. It's basically the treatment card the patient should may put on the fridge, telling him, well, you have to take these medication at that time and for this purpose. And work in progress, the FHIR representation of these content profiles, because we will support both FHIR content and CDA content. And we will support both SOAP-based communication and RESTful communication for the medication service. And CMPD, because we want to support also the FHIR content. The CMPD profile, workflow profile from IHE Pharmacy will support both RESTful and SOAP-based transactions, but it will be a Swiss extension to support this FHIR-based content for the moment. EPR integration. The eMedication service has, of course, to be integrated with the electronic patient record infrastructure. That's a necessity, that's a must. It's not, it cannot be without being integrated. However, it's designed as a slightly distinct component for a distinct component from the EPR XDSB part, from the storage, document storage part, because one key aspect, it's because it has a business logic. It has an aggregation business logic, and it has also its own access right management, slightly different from the access rules for the documents. But it's using the key components of the EPR XDSB infrastructure, user authentication, master patient index, healthcare professional directory, secondary storage for documents. All that is taken from the used from the EPR community. And implementation. The tool we are designing, the additional component we are designing is called the eMedication Primary Aggregator. It implements the pharmacy CMPD profiles. It implements the aggregation business logic, aggregating the different steps that were performed on a medication to start from the initial decision from the physician up to the current state of the medication, taking into account the substitution, the changes of dosages, the changes of frequency. So it can create aggregated view. It does not perform reconciliation. If a physician adds a medication, it is his responsibility to see if something else has to be removed or if it replaces something. It manages specific access rights to medication data, and it acts as a primary system regarding the electronic patient record. One reason for that, among others, is that patients may contribute to their own eMedication plan through the portal. And this means that the original version of the contribution of the patient is in the eMedication primary aggregator. And it's a secondary copy that is in the EPR system. That's why we called it primary aggregator. And finally, eMedication service, proof of concept in one community, CARA, which cover 5 cantons. And we'll make detailed evaluation, validation of the concept of the approach, all the questions related to sustainability, financially, technically, and prove that the path we have designed in the concept for national coverage is realistic, is feasible, and it will be served also an input for the forthcoming eMedication national regulation that will have to be created. So all this together will form this eMedication service, and we hope to be live end of this year, beginning of next year for the users of one community for the beginning. And that's the end of the presentation. If you have any question, I think we still have a few minutes.
Yeah, thanks, Stefan, for this impressive tour for what it needs to establish an eMedication service. And it became also visible that the user community can definitely drive and influence what IHE defines, which is a very important aspect of IHE, of course. Are there any questions to Stefan? I think Walter can unmute you if you want to speak up directly. There are any? Stefan, can you, Walter, can you unmute everybody? Or raise your hand or type something in the chat window if you have questions.